goes, invariably he might have some urinary symptoms, and those include frequency, urgency, difficulty emptying the bladder, the flow that's slower, there's hesitancy, meaning the urine doesn't come out as soon as you'd like it to. It takes a little while before it comes out. And also nocturia, which means you get up at night to urinate. So basically, these are all symptoms of an enlarged prostate. And in the beginning, it's really not a big deal. I mean, getting up an extra time at night or going to the bathroom an extra time and maybe taking an extra minute at the bathroom. But eventually, they start really sort of increasing. And unfortunately, they start really having an impact on your lifestyle or your quality of life. In fact, there's a symptom score that was created. It's called the IPSS, International Prostate Symptom Score. And it basically lists all of these symptoms and tells you, well, how much are you having? 1 to 5. And the most important question is the bothersome score. So if you were to live with these symptoms until the end of your life, how bothered would you be by it? And the reason why this question, this last question is there is because these symptoms in the beginning, they're really not as dangerous for your health. And later on, if they progress, and certainly if they last, eventually they become very dangerous because eventually it increases your chances of getting not being able to urinate at all. But in the beginning, it's a question of quality of life. So the bother index is also a part of the validated questionnaire, and the more you get bothered by these symptoms, the more you want to do something about them because they start having an impact on your quality of life. So there are really 3 categories of potential treatments. The first one is medical, so meaning you take a medication, and typically, it could be an alpha blocker, which is a medication that blocks the alpha receptors in the body, which are present, for example, in your prostate. And the prostate is made up of 2 things: of smooth muscle and of gland tissue. The gland tissue excretes the fluid of a very specific content, and the smooth muscle also is. So basically, if you take an alpha blocker, you block those receptors in the prostate. It relaxes the prostate, and although it is bigger, because it gets relaxed, you can urinate a little bit better. So that's one type of treatment, alpha blocking. That's one end of the spectrum. The other end of the spectrum is surgery, and probably one of the most invasive surgeries and bigger surgeries is it's sort of kept for people that have huge prostates. And it's basically, you get an incision in the middle of your lower abdomen, and we find the prostate and remove the prostate and rehook up the bladder to your urethra, or core up the prostate and close the defect. And that's called a suprapubic prostatectomy, which distinguishes it from a retropubic prostatectomy, which is a cancer surgery. So there is such a thing as removing someone's prostate entirely, not for cancer, but rather for obstructive symptoms, because the prostate is so large. Now, in most people, that's not necessary. A step back from that, in terms of the minimally invasive stuff, is the traditional TURP, or commonly known as Rohrer. I can't pronounce that word, but basically what it is putting a scope in the urethra and then from the inside scraping the prostate to remove as much prostate as you can from the inside out in order to open the channel for the urine to come through. Now, there had been developed another procedure that's sort of also even like a little bit less invasive, which is the resection of the prostate, but rather than doing it with a resectoscope, i.e. with a metal loop that scrapes pieces of prostate out, instead of doing that, doing it with a laser. Now, a laser, there's probably like thousands of types of lasers depending on the wavelength and depending on the depth of penetrations and whatnot. And the laser that's used for the vaporization of the prostate is a wide, narrow, in terms of like it's a superficial but wide laser. It's called a green laser. So green light laser, it vaporizes the prostate as it touches it, and the benefit of that is that it vaporizes the prostate. The benefit is that as it is vaporizing the prostate, it's also coagulating. So the blood loss is minimal. There's almost no blood loss, and patients, because there's no blood loss, and it heals rather quickly. You can go home the same day with a catheter. There's no need to keep a catheter with the circulating water to make sure that the bleeding doesn't get worse and whatnot. So it's a less difficult procedure to undergo for a patient. There is a middle of the road, not surgery, but a procedure which is minimally invasive, and it's called UroLift. What UroLift is putting clips, it's like staples, that basically, imagine the prostate is like this, and each staple that you put opens the prostate. So the prostate is like this, and you open it up. Let's say you're looking at me, and now you're looking through the urethra, and all of a sudden you're going to see the urethra close shut. That's because the prostate is impinging. Each lobe of the prostate is impinging on the middle of the urethra. So now you don't see my face anymore, and then I put a clip like here, it opens it up. I put another clip like here, it opens it up. So now you can see the inside of the bladder. So you go through the urethra, you're going through the urethra, and all of a sudden it closes because the prostate is pushing on the middle of the urethra on either side. A clip here and a clip here. So that procedure does not require surgery. There's no cutting. You just put a clip to the middle, and another clip. The clip is basically, all it is like two clips. And in the middle of the clip, there's a suture. And there's a titanium clip and a titanium clip. And then there's a suture, and this suture basically, gets the prostate out of the way. One clip is sitting right outside of the prostate and right on top of the capsule, the outside of the capsule. And the other clip is on the inside of the urethra. I'm gonna just do one side of the prostate. You put one clip here, you put one clip here, and you open it up. So now this is open. Now here, open it up. We put one here, one here. So basically 4 clips, sometimes 6 clips, depending on how long the urethra is. So this procedure, which is basically putting clips and opening the urethra with the clips, that does not require any cutting. There's no bleeding. There is no ejaculatory dysfunction or sexual changes. With the other ones, with the TURP or the green light, yes, because if you remove the prostate, guess what? You're not going to be ejaculating anymore, because now the bladder neck is gone, because the prostate comes up to the bladder neck. If I remove the prostate, you're not going to be ejaculating. First of all, there's no more prostate, so there's no ejaculation forcibly. With the UroLift, you continue to ejaculate. So why doesn't everybody get UroLift? It seems so great. Well, not everybody's a candidate. If your prostate is too large, if you let it go too much, and if the distance between the urethra and the outside of the capsule of the prostate is too large, then we can't do it. It's not going to be effective. So the UroLift is, if someone has middle of the road symptoms that are bothersome, they can get that procedure, and it could be very effective. Has it been around for 100 years? No, it's a new-ish procedure. There is great 5-year data, but there isn't like 20-year data. Now there is great long-term data because we've been doing that surgery since the 80s. But in the green light, there's great long-term data that's been around for 15, 20 years. But the UroLift is only been about 10 years, and there's good 5-year data. But it's a reversible procedure. There's no ejaculatory dysfunction. It's done in the office. You don't have to have big surgery. You don't have to have any bleeding. It's reversible. If it doesn't work, or if it works but only for a certain number of years, then you can always. It doesn't preclude you from having a regular TURP or a green light. So it doesn't preclude subsequent procedures if it was to fail immediately or in the intermediate term. So that's the benefit and risk for each one.